Torbay charts patient decision aids. Thank you for agreeing to spend more time with me and help with the analysis of value proposition of Torbay charts and build a business plan. Through non-verbal communications, I sensed that I had not said enough to impress you regarding the Torbay charts. The 2 points that you raised during our meeting are Torbay chart sounds like a pathway document and the sale value to the CCG is not attractive. Despite the obvious advantages of using PDA in day-to-day practice, its use is not widespread. This is because current PDAs do not give an overview of all options, nor do they match treatments to the stage of the disease. Almost none have self-directed comparison of options, and they are visually unattractive. The one-size-fits-all approach does not reflect the available local resources. They are perceived to be time-consuming and impractical to use during consultation. Some examples of currently available PDA for knee arthritis are shown. Therefore, there is a need for a completely different approach to meet the Montgomery standard option discussion, and Torbay chart addresses all these shortcomings. Torbay chart PDA is arranged in multiple layers, starting with a friendly infographic interface where information can be given in quanta. The layer 1 chart can be printed and used during consultation. It provides a drone view of the whole process, matching different treatment to the stage of the disease. Layer 2 provides further information about each treatment and is on our website. It provides information as to what each of those options mean, associated risks, benefits, and burden. Just like any comparison website, patients can do self-directed comparison of various options. Let us consider 2 scenarios. Patient A enters the pathway at an earlier stage of the disease and treatment options suggest more of a self-management and simple interventions. However, for patient B who enters the treatment journey later has more surgical treatments as options. Patient B may still choose to have non-operative treatment. In contrast, for patient A, one should not be offering or discussing surgery as it is inappropriate. This single tool can be used in both primary and secondary care. It could serve as a passport for the patient when they move from one set of treatment to another over a period of time. We did a pilot with 107 patients more than 2 years ago in our trust, and over 90% of the patients said that they understood the treatment options available for them. They understood the recommendation and that it enhanced the shared decision-making conversation. At 2-year virtual follow-up, 1/3 of the patients still continued with non-operative treatment methods. What was interesting was that the originally 5.6% patients who came into consultation expecting to be listed for surgery chose non-operative treatment after going through the options appraisal. Of these, 2% were still happy not to undergo surgery, thus suggesting that the use of PDA is not a delaying tactic. On an average, we see around 1,800 patients per year with both hip and knee pain. Our conversion rate to surgery fluctuates between 34% and 42%. If we were to consider a modest 2% sustained reduction in operations, we would be avoiding surgery in at least 35 patients year on year. This equates to a potential saving of at least £200,000 per year in our hospital alone. Translating this to the NJR figures, and with the use of an efficient PDA and STM, one could potentially save at least £26 million per year for the NHS. This is a conservative estimate, as much higher figure of surgery avoidance is quoted in published literature. The practitioners felt that the use of Torbay chart during consultation made it easy and focused. More importantly, they felt that it did not increase the consultation time. Printed Torbay charts served as a focal point for exchange of facts and leading to a very engaging conversation. Patients seems to understand why some options were appropriate and why some were inappropriate to them. Torbay chart truly gives a personalized, fully informed treatment choice and thus likely to meet the expectations set in the Montgomery verdict. Following the presentation in our regional SDM meeting, Bristol team were very interested in using Torbay charts. Their SDM group went through a systematic process and considered all available tools, including the one that was promoted by NHS England, but chose Torbay charts as their preferred tool. We have customized the information in both first and the second layer to reflect the local resources, like adding escape to pain pathway, thus making it bespoke for them. Research fellow from University of Bristol is planning to do a qualitative and quantitative data collection from this trial. We are developing Torbay charts for 3 shoulder conditions and for management of low back pain for Bristol team. However, I was not involved in the business negotiation part, and I am told that the sale figure agreed was based on gaining entry into the market and the value of having a free evaluation of the tool. Already, few of the neighboring CCGs are interested. Regional Orthopedic GERFT lead is enthusiastic, and he has placed Torbay chart as a tool that could be used for restarting elective work in his document. Professor Alf Collins from NHS England is aware and has supported this project right from the start. There are some opportunities to trial this at primary care level and potentially collaborate with Winton Centre. The concept is not just limited to orthopedics. I have developed the first layer information for management of blood pressure, COVID-19, burnout, etc. So, I would be most grateful if you could help me to project the Torbay chart concept in the best possible way, suggest a strategy to engage various business dialogues to show the true value proposition of Torbay chart. Thank you very much.